Greetings, everyone, and welcome to Mbongi 2, another phenomenal village conversation of things that's important to each and every one of us. I am Dr. Ethiopia Jackson, serving as the 46th president for the Association of Black Psychology. And we are sending this live, so I'm going to start it now, to our YouTube page so that others can join us in this phenomenal experience. Once again, welcome to each and every one of you. I'm Dr. Ethiopia Jackson, 46th president for the Association of Black Psychology. I have the distinguished opportunity now to present an award, a presidential award, to one of the key figures to the success of this program. This is for the Honorable Mark Morial, who's the CEO and president for the National Urban League, which funded this phenomenal situation. I will allow Dr. Cheryl Grills to tell you more about this particular grant, but in this moment, I wanted to appreciate Mr. Morial for his efforts on behalf of Black communities and communities of color everywhere. So if you're here, I invite you to share a few comments. Mr. Morial? Were we able to, I know he was experiencing a bit of technological glitches. Were we able to pull him over? So in the interest of time, I'm going to introduce and turn this over to our very own past president of the Association of Black Psychologists, Dr. Cheryl Grills, as she orients us and brings us to this phenomenal Mbongi. Enjoy, family.
Good morning, family. I hope you are all in good health and good spirits. I'm going to go right into our presentation because we have lost some very precious time. I'm going to share my screen and start it. Okay, can everyone see? I'm hoping that everyone can see and hear okay. If not, yes. Send me a message. You're good, excellent. Okay, so we are here today to present on research for us and by us, the impact of COVID-19 in communities of color. And this is being presented as part of the work of the Alliance of National Psychological Associations for Racial and Ethnic Equity, what we refer to as the Alliance. And this project was done with support from the National Urban League, who served as the fiscal sponsor for the project and worked with myself and Representative Karen Bass to raise basically about $1.7 million in 3 to 4 months to fund the work that you're going to hear about. So this is a needs assessment effort to inform the Congressional Tri-Caucus and the Native American Caucus about COVID's impact on communities of color. So this alliance is a partnership of our respective psychological associations, including the Asian American Psychological Association, ABPsi, the American Psychological Association, the National Latinx Psychological Association, and the Indigenous Wellness Research Institute. This is what we call phase 1 of a 2-phase research process. And phase 1 was considered a rapid assessment designed to address 4 major questions that were designed not by us. This is truly a community-based participatory process. And so the questions that drove this research were designed by the members of Congress. And essentially, they are trying to understand the differential pandemic experiences of communities of color, and given the last recession in 2008, how these communities will be affected. They wanted to know about the health and mental health effects on communities of color and the economic impact on these communities. And the information that is cultivated by our respective associations is fed directly to the members of Congress and to a convening that will be held by the Urban League of the national civil rights organizations. There'll be about 10 to 13 of them. Very, very briefly, our methods in brief. This was a huge undertaking from December 2020 through April 2021. Our sample, we have various, it's a mixed methods approach with multiple data sources. The overall survey sample size with direct data collected by the various alliance organizations was 29,944 people. In addition to that, APA did additional analyses on administrative data, and that was a sample of 154,064 elders using the Household Pulse survey. And then we also have data that came in from subject matter experts. And you'll see here, because of time, I'm not going to go through it, but each association had its own sample size, its own methodology, if you will, but we all shared a common set of items in a national survey so that we would have the opportunity to see the picture from an aerial view equally in terms of the impact on all of our communities. The subject matter experts, I just wanted to very, very quickly tell you about them. We have subject matter experts in education, economics, health policy, epidemiology, polling, and social policy. And they each are examining a set of questions that were derived from the work by the Alliance and in answer to the questions posed by the members of Congress. I will share some headlines of their work at the very end of this presentation. Lastly, before I turn it over to our first guest, is that we have been actively disseminating this information. So we have done briefings with the Asian American Caucus, the Hispanic Caucus, the Congressional Black Caucus, the Native American Caucus. Next week or the week after, we will be presenting to the White House Health Equity and COVID Task Force. We also presented to a national group of philanthropists. And lastly, we will be doing the civil rights organizations and a major media discussion. So with that, I want to turn it over to our first guest representing the Asian American Psychological Association. There are two representatives. One, Dr. Annie Saar, representing AAPA, and then Dr. Reynald Samoa, representing Native Hawaiian and Pacific Islander findings. And so, Dr. Samoa, I'm going to turn it over to you.
Thank you so much, Cheryl. So my name is Reynald Samoa. I am the lead for the Pacific Islander COVID-19 response team. I'm also an endocrinologist in Southern California, and I've been tasked to present the NHPI part of the survey. Next slide, please.
Oh.
Sorry. So we were able to get about over 1,200 respondents. We had a good distribution of ethnicities that followed along the census lines, with the only caveat being that Native Hawaiians have the predominance of our populations, but working with the Indigenous Wellness Research Center, we opted to have Native Hawaiians in Hawaii surveyed by them. And it was a good distribution across the states, where we got the majority of respondents following the census in places like California, Hawaii, Washington, Oregon, Arkansas, and Utah. Next slide, please. So this was truly a community collaborative effort. Our communities have traditionally been invisible, and oftentimes we're told that they can't get any data for us. And so we reached into the community wisdom and engagement and trust equity that was already there to do this work, and it was very successful. Next slide. So what we gained from it was a significant amount, and I'll show you on the next slide why that is. It's the first time we got any data looking at upstream factors as to the real reason why people are making the decisions they're making during the pandemic. And when we talk about disproportionate effect and impact the pandemic has had, it's important for us to gather these upstream factors. And like I said before, we're traditionally invisible to a lot of data collection methods. And oftentimes they just sort of throw their hands up and tell us that that's the way it is. But this effort was very, very thoroughly vetted up and down by our community, by Pacific Islander researchers as well, and showed that we can be successful if we utilize those resources that are prevalent in the community right now. It also allows us to focus our efforts so that we can, there's not a lot of resources to help these communities, and so we have to be very judicious about how we spend these resources. Next slide. So here's the reason why it's so important for us. In those states, in the 20 or some odd states that report the NHPI data, Native Hawaiian and Pacific Islanders have the highest case rate in 16 out of the 20 states that collect their data. And in the 19 states that have mortality data, Native Hawaiian Pacific Islanders, 11 of them have the highest mortality rate. So that disproportionate impact is found heavily in our very vulnerable community. And so it behooves us to try to find things that can alleviate some of this disproportionate impact. Next slide. Next slide. One of the most concerning things that we pulled out was that a large percentage of our population is hesitant to get the vaccine. Next slide. The most concerning thing for us was that this goes against the national strategy to vaccinate the majority of our population. Next slide. The one before. Looks like we're just going forward. That's okay. Okay, I can go. So about 43% of our population showed hesitancy to the vaccine. The thing that's the most concerning about this is about 44% of our working population, that the 25 to 44 year age, which is the group that has the high percentage of essential workers, are hesitant to get the vaccine. And so when you have essential workers that are hesitant to get the vaccine, this threatens their herd immunity and fights against the national strategy. So why would it? We also noticed that that in our other analyses, we demonstrate that the higher the income level and the higher the education level attained, the less likely you're going to be hesitant to get the vaccine. So having higher educational degrees and higher income seem to be protective. But when you're dealing with a population, as you can tell by the large percentage of our population that report having having incomes less than 50,000, and also the small percentage of our population that have a bachelor's degree and advanced degree, you can see we're extremely vulnerable to any type of health crisis. And so I also should say that the vaccine hesitancy differs from state to state. We noticed that in places like Arkansas that have a low vaccination rate in NHPIs, their rates of vaccine hesitation in the survey was about 71%. So it correlated and also almost predicted what the vaccination rates would be. In Utah, it was about 64%, and a similar things happening there with the Pacific Island community. And then in places where there's high vaccination rates, we demonstrated that the survey already predicted that at having vaccination rates as low as 25% in Oregon and Washington, where their rates of vaccination are higher than 70%. Next slide. And as you can see, this basically is just another way of saying that Native Hawaiian and Pacific Islanders have a large percentage of people that are vulnerable based on low income and having significant stressors because of that. Next slide. Besides income, we noticed that there are issues that have absolutely nothing to do with income and education level. This is a graph that shows the difficulty in seeing a healthcare provider before and after the pandemic. And as you can see, there's maybe a little bit of a tendency for people who have lower educational levels to have more of a difficulty in seeing a healthcare provider before the pandemic. But after the pandemic, everyone, it doesn't matter what the education level, they all noted there was a significant difficulty in reaching their provider. And when you're talking about early intervention to help improve the mortality rate or the outcome of COVID, you can see how a delay in seeing your provider could be detrimental in that. And the largest reason for not seeing or having difficulty was the conversion to electronic telehealth. Next slide. And very pertinent to our discussion today, we did note that there was a large percentage of depression and anxiety reported by Native Hawaiian and Pacific Islanders, and it seemed to differ by ethnicity. And so as you can see here, our Marshallese community had a very high rate of depression and anxiety. Notable that they also had the the highest rate of vaccine hesitancy as well. Next slide. And so what we've learned is that we're predominantly low income and low education, and that is significant roadblocks to us improving the current trend in COVID that is experienced by Native Hawaiian and Pacific Islanders, and that they're at increased risk of severe illness from COVID-19 due to seeking healthcare. But the silver lining around this information was the importance of partnering with community-based organizations and leveraging their trust equity in the community to get this much needed information out. And so we're hoping that this information helps fill some of the critical gaps that are not present in the critical gaps that are present in federal, state, local government, because this information is not reported anywhere. And so there's a significant gap that's being filled by this survey. Thank you so much.
Thank you. Now, Dr. Saw.
Thank you so much. So I'm going to jump right in, and Cheryl, you can advance to the next slide. Share data from on Asian Americans from our needs assessment project. We were able to survey over 3,700 Asian Americans all across the country and get good representation covering the vast ethnic, age, education, income, and geographic diversity of Asian Americans. Next slide. This was in large part due to a huge network of community and advocacy partners who worked with us all throughout different aspects of the project. Additionally, our survey was translated into 9 different Asian languages, which helped us to be able to reach our more limited English proficient Asian Americans. Next slide. As I talk through some of our, just hitting up some of our key findings, we've been using this language or this term of syndemic to describe what has been happening with Asian Americans during the pandemic. Oftentimes people talk about twin pandemics of COVID-19 and, as you all know, a surge in anti-Asian racism. But we like the term syndemic because it refers to how these different threats interact with one another in ways that you can't quite tease apart. And when it comes down to policy and funding, we really need to consider all of these threats in concert. So as you all know, many of these threats, whether it's racism or health and mental health challenges or economic challenges, these are not new to any of our communities, but they have been magnified in the context of the current pandemic. Next slide. So I want to share with you some of our some of the stressors, the most prevalent stressors being reported by Asian Americans during the pandemic. As you may know, Asian Americans tend to underreport mental health concerns of all of our different racial ethnic groups. Historically, Asian Americans have had the lowest prevalence rates of mental health concerns. But in the context of COVID, stress related to mental health concerns was in fact the top stressor that we found, affecting over half of our sample, along with social distancing and quarantine. Another interesting finding to alert you to is that racial discrimination is also a top stressor faced by Asian Americans. And again, this is quite a new finding for us within Asian American communities who have always experienced discrimination, but not necessarily at the level that Asian Americans are experiencing now. Next slide. You can just advance to the next one. Thank you. As I mentioned, anti-Asian racism has dramatically increased since really January of last year, with the most dramatic incident being the Atlanta area shootings that killed 8 people, including 6 Asian women. Part of this project entailed following up with respondents to the Stop ABPi Hate Reporting Center, which has been collecting reports from individuals who have experienced racism during the pandemic. By far the most reported anti-Asian racism are verbal assaults and physical assaults, but other forms of racism include civil rights violations, including being denied access to services, to public transportation, and being turned away from businesses. Next slide. Our national study is distinct from other published reports on anti-Asian racism, given our very large sample and the multiple Asian languages our survey was offered in. In our work, we found that 61% of Asian Americans have seen an increase in cyberbullying. About a third have faced discrimination. Another third report that discrimination is a major source for them. And I think this is really the most profound finding along with regards to this issue, that is that 3/4 of Asian Americans believe the US has become more dangerous for this racial group. And that really speaks to the impact of racism on safety, security, and well-being and mental health. Next slide. Economic demands are also being felt by Asian Americans, whether it has to do with lost work or lost income, being fearful of being laid off, and also the synergistic relationship between businesses suffering in the context of racism, and also how important it is for services and things like unemployment to really respond to the unique features of our communities. Next slide. In terms of economic demands, over half of Asian Americans reported that they or someone in their household have experienced a loss of employment income since the start of the pandemic. Over a quarter expect someone within their household would lose employment income in the coming months. And Vietnamese, Korean, and Filipino Americans were most affected when we disaggregated the data. And this slide also shows some of the other economic demands on Asian Americans right now, whether it has to do with needing help filling out unemployment forms or help with utilities or housing. Next slide. In terms of mental health and health challenges, again, these are not new. We have experienced gaps and challenges with respect to linguistic and culturally appropriate care for Asian Americans, but the pandemic has magnified these challenges, especially as they intersect with racism and economic demands and other COVID-era stressors. Next slide. So we found that 44% of Asian Americans reported a decline in self-rated health. 4 out of 10 have delayed getting medical care. 4 out of 10 are reporting anxiety or depression symptoms. 29% say they need help accessing mental health services, and that help is most profound with those with current mental health symptoms. So that is unmet mental health need, right? And also our limited English proficiency, Asian Americans, and young adults are also in greatest need of mental health services. And young adults and low income are most vulnerable to health and mental health challenges at this time. Next slide. So in closing, I just want to show again the syndemic framework that we're using, because I think it's really helpful for us to understand how all of these different stressors and impacts within the context of COVID are really impacting our communities, our Asian American, as well as other communities of color in ways that we need to so that we really need to design policies and intervene and conduct our research in really sophisticated ways that address these co-occurring and interacting challenges, because they do, as we all know, have long-term impacts for our well-being. So thank you so much.
Thank you very much, Dr. Saw. And now I would like to turn it over to, Dr. Suzanne Randolph Cunningham to share the findings for Blacks and Afrikaners in the U.S. Dr. Cunningham?
Great, thank you, Dr. Grills, and thank you to the team members here. I'm very proud to be a part of this team and also acknowledge the ABPsi team that helped with this. They were ABPsi members, students, and also professional members that were involved. Worth saying that all of this work that you're hearing about took place in less than a year or so. So this was a tremendous amount of work, data collection, research, all approved by IRBs or institutional review boards. So I want to also compliment my colleagues and the associations involved in this for this gigantic effort. Next slide, please. I'd like to point out our sample, 2,480, was across primarily 6 states: California, the DC, Maryland metro area, Louisiana, Michigan, the Mississippi Delta, and Texas. We did have specific locations like Los Angeles, the eastern shore of Maryland for some rural areas, as well as the nearby DC suburban areas, New Orleans, and some rural areas in Ascension Parish and East Baton Rouge. And also in Michigan, we did Detroit, and in Texas, we did Houston and rural areas. You can see in the lower right-hand corner that most of the sample, 47%, were in urban areas, 36% were in suburban areas, a small percentage, 13% in rural areas, and 5% of the respondents said they weren't sure what type of region or area they lived in. Next slide, please. In terms of mental health, we'll go quickly, but we had about the same rate as you just heard from Dr. Saw. 38% who were at the cutoff that suggested that it warranted professional assessment, 38% with anxiety symptoms and 39% with depression. And we asked about the past couple of weeks or so. So we also learned from this that people are experiencing this anxiety and depression real time, not just over the past year. We collected the data February 1 through March 29th of this year. So about a year into the pandemic itself. 40% when asked about did they have informal or formal support said no, but they wish they had had it, or either that they had had more of it. We also collected data from community representatives in these 6 primary areas where we were. And one of the community voices in the Mississippi Delta indicated that it was fine that churches were lending support in distributing food, some more material support, if you will, but that would they didn't feel that it was enough. Next slide, please. We do make some recommendations with respect to mental health, primarily for us around mobilizing the Black professionals that are involved in the training. And so we thought that with culturally accountable strategies that, like our president likes to say, that we could train more professionals with the kinds of CEUs that you're receiving here and the kinds of professional trainings that we have as an association to deliver these services, because there certainly won't be enough of us. In terms of health, we did ask about a number of health risks. And on the left there, you'll see the primary ones that emerged, the top 6 or 7, and they all map onto what the risks are for COVID: hypertension, 23%, asthma, lung disease, heart attack, diabetes, obesity, and cancer. We do know that a lot of people also lost their insurance due to having lost their employment. And so it was challenging for them to even seek medical services or mental health services when they did have a need for that. The community voices told us that the healthcare and mental health services are unaffordable because of this underinsurance or lack of it altogether. And also that access was just very limited. So in rural areas, we did hear about the fact that you have small hospitals that can only serve 30 people or so, but the need is tremendous. Next slide, please. In the next section, I'm going to talk about the vaccination decisions. Did people get it, plan to get it, don't plan to get it, and some of the factors that are influencing their decisions. Most importantly were the side effects of the vaccine, safety, and effectiveness. Over half for each of these were reported by the participants. And that's in contrast to what we have below the line, the things we traditionally think about, relying on whether family and friends are getting it, whether or not our faith leaders or professional healthcare providers are telling us to get it. And those were less influential than the actual vaccine itself. So the community voices told us that we need to put less emphasis on trying to convince people that this is not a Tuskegee, this is not the genocides of the HIV experience, etc., but that we really have a real need to get vaccinated because of the science around it, but also that we need to reassure people that about the side effects and give them the truth about its safety and its effectiveness. Next, please. We also did a constellation of variables called the social determinants of health, which I'm sure many of you have already heard about. These are the factors that are causing or have been designated or indicated as causing much of the disparities and inequities we see, aside from things like structural racism, of course. And so for some of these, we found that the COVID-19 pandemic affected them in terms of food security. As you might suggest, it was higher food insecurity because of things like food swamps, too many fast food outlets, and not enough fresh produce, or deserts, not enough food at all, period. In education, we heard about ghost children, children being lost to the system, and 25% of the children unable to do any remote learning at all. Housing stability and economic stability, as you've heard about from Dr. Saw and others, were also present here, with people doubling, with the number of people doubling a percentage in terms of those who were on unemployment. These social determinants also pose some barriers to coping effectively. Although we saw a lot of positive coping, there was also a great deal of negative coping. But some of those barriers were the access, the lack, again, due to loss of employers' insurance. Some people had stigma about standing in food lines. They didn't want people to know that they could not feed their families when they previously could do so. The environmental issues, there were floods, hurricanes, tornadoes, wildfires that pose asthma threats in the West and so forth. The technology we all know about, the limited bandwidth, but also not having technical support. So the school gives you all this equipment, your employers give you all this equipment, but I don't know how to use it or use it properly. And then transportation, not just in the urban areas where things were reduced in terms of the COVID restrictions and so fewer buses and subways and so forth, but also in the rural areas, it was just exacerbated. What I want to talk finally about is this intersection of racial injustice and COVID-19 pandemics, you heard referred to as a syndemic. Next slide, please. And I want to thank Dr. Kevin Coakley and his students for a lot of the work that was done here, and one of our students on the project, Stephanie Castellan, who presented a poster yesterday on these concepts. First and foremost is the fact that the way one perceives the threat of COVID-19 to their own health also is associated with anxiety and depression. So as you might expect, also higher levels of anxiety symptoms and depressive symptoms were related to people feeling more seriously about the effect of this pandemic or the actual virus on themselves. However, it wasn't related. Anxiety and depressive symptoms were not associated with how serious they viewed police violence. And our community voices suggested to us that perhaps people have found ways to cope more positively with the police violence than they have with COVID-19, which was newer in our communities. But we do hope that there'll be more funding and opportunities to explore these interrelationships further. Next, please. And this slide, if you just look at the tall blue bars on the left and the short blue bars on the right, is just basically telling you that people who got vaccinated were more trustful of the system. People who didn't had higher cultural mistrust. And those were both the people who hadn't got the vaccine at all and those who said they planned to, even though they hadn't had it. Next slide, please. Just want to close with some of our next steps. And we propose to continue this work, working with the president, who's a co-investigator on the project, as well as the board and other committees of the association, as well as our colleagues, to try to find additional funding, to do additional analyses to understand these preliminary findings better, but also to form partnerships that will allow us to address these problems that we've highlighted here. Thank you very much. And come to our session at 4 o'clock to hear more.
Thank you, Dr. Randolph Cunningham. And now, and this is the research team. And by the way, folks, I'm not advancing these slides. Something is taking over in Remo and it's advancing without my touching anything, so forgive me. But now I'd like to introduce two colleagues from the National Latinx Psychological Association, Dr. Cristalis Capiello Rosano, and then Dr. Fiorella Carlos Chavez.
Good day, buen dia. On behalf of NLPA, I want to thank ABPsi for inviting us and sharing this space with you. So hopefully you'll get to see our data, but the results that we're going to summarize, they're based on 3 separate data collection efforts. One, which included 2,300 Latinx adults living in the United States, 536 adult Latinx immigrants or Latinx individuals were born outside of the United States, and 923 Latinx youth between the ages of 13 and 17. This data was collected during the 3rd wave of the pandemic between November 2020 and January of 2021. In terms of who was in our sample, the adult sample was mostly composed of individuals who identified as Mexican American, also racially white, and the mean age for participants was 33 years old. Next. Most of the sample was either married or single, and 91% had US citizenship status. Next. Median income was a little over $49,000 a year, but 59% of the sample had high school diploma or less, and about 40% of the sample was considered an essential worker. Next. In terms of the Latinx sample that was born outside of the United States, about 36% was a US citizen, followed by being a DACA recipient, or having some form of temporary status here in the US, and most came from the state of California. The adult immigrant sample was also fairly young, almost 91% was under the age of 40, and most identify as women. Next. Most also identify as either Mexican or Mexican American, and racially, a majority identifies either white or Indigenous. Next. In terms of the youth sample, most were in high school. About half of the sample identify as female, and race. And as I said, most of them, the mean age, my apologies, was 15 years of age. Next. Racially, the sample mostly identified as white, followed by other biracial and Black, and ethnically either as Mexican or Mexican American. In terms of the most salient data points that we have to share with you, almost half of our adult participants said that even though they knew of somebody who had been infected with COVID at work, they were forced to go to work. This percentage was higher among essential workers, where about 67% of them had to go to work. We were also very concerned by the rate of lack of testing among individuals who had symptoms, but yet 20% of them were never tested. And overall, about 27% of adult Latinx individuals knew of somebody, a friend or a family member, who had died because of COVID. Next. One of the most significant things that we found in our data, this is a term that Dr. Germán Cadenas from our team coined. We see that within the immigrant sample, again, these are adults who were born outside of the US, about 33%, about 36% were US citizens. When you looked at the cases of infection and symptoms, if you were an immigrant without US citizenship, you were more likely to have had symptoms and never be tested, and you were also more likely to test positive. Next. In terms of, for our Latinx youth, we were very concerned to see that about 80% of Latinx youth said that they engage in some form of prevention, either wearing a mask, washing their hands, avoiding crowd places, but yet 70% of them knew somebody that had been infected with COVID, and almost 11% were infected with COVID themselves. We also noted that youth, Afro-Latinx youth and Indigenous youth who wore masks were more likely than white youth to experience discrimination when wearing a mask when they were at a supermarket or some other place. In terms of economic impact, on the next slide, almost half of the Latinx of the adult sample, so a reduction on hours or furlough. More than 1 in 3 had difficulty paying important bills, and about 25% had difficulty paying for medication. Next. The economic impact was also pretty significant within the immigrant population, with about 25% saying that they had a reduction in hours, and again, 1/3 saying that they had difficulties paying bills such as the rent or mortgage. Next. About more than half of Latinx youth said that they were concerned or very concerned that an adult in their home would either lose job, and 1 in 3 were very concerned that the family would run out of money and not be able to pay rent or buy food. Next. More than half of the Latinx adult samples were experiencing more symptoms during the pandemic. And we also noted that about 80% of them saw that 1 or more children in the home had more behavioral problems or psychological problems during the pandemic. Mental health symptoms were even worse among essential workers. Next. We see the same citizenship shield dynamic playing out, where 2 in 3 immigrants without U.S. citizenship were experiencing more depression and anxiety symptoms than their counterparts with U.S. citizenship. Next. Within the youth sample, 35.4% were experiencing depression or anxiety most days than not. And we're also very alarmed by the percentage of youth who either engage on unprotected sexual activity, use of drug or alcohol in order to cope with the depression or anxiety symptoms during the pandemic. Next. And actually, I will, if my colleague, Dr. Carlos Chavez is still present, I will ask her to cover the next slides.
Good afternoon, everyone, and thank you for joining this presentation. I will briefly cover some of the results from the assessment on food insecurity among Latinx communities, and in this case, of Latinx adults. So we found that 52% of all Latinx adults were food insecure, and this was more pronounced among men. 53% of men were more food insecure. Next slide, please. For Latinx adult immigrants, we found that 46.5% of all Latinx adult immigrants had difficulty getting enough food or healthy food for a balanced diet. And 1 in 3 immigrants with US citizenship were food insecure. And we can see this clear contrast as Dr. Capiela Rosario mentioned, that the concept of citizenship shield where 2 in 3 immigrants without US citizenship reported being food insecure. Next slide, please. For youth, remember that these were Latinx youth ages 13 to 17. We found that 53% of all of them were food insecure. And this was more pronounced among girls than boys, where 59% of all girls were food insecure, while 53% of all boys were food insecure. Next slide, please. And we want to thank all the researchers that were part of this collaborative effort. In NLPA, Cristalisca Piela Rosario, the lead principal investigator, and all the other collaborators, Evie Garcia, Germán Cadenas, Alison Cerezo, Delida Sanchez, and Lucas Torres. And we also want to thank all the graduate student and research assistants for this project at our various institutions. Thank you for your time.
Thank you. And now we will move on to the American Psychological Association, Dr. Jennifer Kelly, who will share APA's findings on elders of color. Or perhaps not. Okay, here we go. We can't hear you. Unmute yourself.
Thank you. Yeah, I thought I had unmuted. My name is Jennifer Kelly, and I'm the current president. And I want to thank the president of APA, and I want to thank the Association of Black Psychologists for allowing us to be a part of this great research. And what we specifically looked at APA was the relationship between the impact of COVID on the older adults of color. And so these were the questions that we were looking at. One is, what is the mental and physical health status of the older adults of color during the COVID-19 pandemic? How has the mental and physical health status of these populations changed over the course of the pandemic, over time? And number three, what are the characteristics of vulnerability and resilience among these older adults? And fourth, what policies may improve the health and mental health outcomes? Next slide, thank you. And so it was the primary research design was analysis of the Census Bureau's Household Pulse Survey, the HPS. And we had from that gathered data that included over 154,000 respondents. You had over 60,000 Blacks, about 33,000 Asian Americans, and about a little bit over 60,000 Latinx respondents. And we also did further analysis using the Alaska Department of Health and Social Services, which 541 data points, as well as the University of Washington Indigenous Wellness Research Institute, which is the IWRI, as a COVID-19 Communities of Color Needs Assessment. And we had 644 in that sample size. And so as part of the Household Pulse Survey, we looked at individuals that were 50 years of age and older, and we looked at the race and ethnic background of non-Hispanic Black, non-Hispanic Asian Americans, and Hispanics. And for the ADHS sample, we looked at individuals ages 45 years and older, although I don't like to think of those as older adults. And they reported their race, ethnic background as Alaska Native or American Indian. And then the IWRI sample looked at individuals ages 5 years and older. And they were Native American, Alaska, American Indian, Alaska Native, First Nations, so that a pretty comprehensive group. And we had the modeling strategy of mental health that looked at depression and anxiety, and we looked at general health, where it was fair or poor versus good, very good, and excellent. And can you, next slide, please? Because I want to go into the results. So what we saw was the time trends in terms of the mental and physical health of older adults of color. We found that more than 1/3 of the older adults had elevated rates of mental health symptoms across all three racial and ethnic groups. The rates that were 2 and 5 were especially high among the Latinx older adults. And when you looked at the time estimates for anxiety or depression with this group, what we saw was a curvilinear trend in the prevalence among Hispanics and Blacks. And what happened is that we saw more depression and anxiety increasing during the summer months of 2020. It began to drop down to starting levels by the end of the summer months and into the fall, and then it picked up again in the winter. And overall, we saw a linear increase in the prevalence of fair to poor general health over time. Thank you. And so the next slide shows that the linear associations between anxiety and depression rates and COVID-specific mortality rates. So you can see that it's a linear association. When you look at it to the second graph, is not so easy to see. But there was association specifically pronounced among Asians, but it was less sensitive in older Blacks and Hispanics. And in terms of variability in mental and physical health among older adults of color, and you can see that there is considerable heterogeneity in the mental and physical health conditions across groups and in regions of the country. And you could just look and see the difference there. And both geographic and within group heterogeneities are important to just keep in mind when you're thinking about the mental and the physical health among these diverse groups of people. So you can say that there is not a one size fits all as it relates to what you're going to be looking at in terms of policies. But it would really vary from the states, because you can see that there's much variability as to the race and ethnicity in terms of depression or how anxiety and depression and how they saw their physical health. Now, I thought this was a very interesting trend to see, and it is so pronounced. So we were looking at what happens when a person ages over time as it relates to mental health problems. And what we saw was this trend, and we call it resilience against mental health problems. And it comes with the aging process across the older adults. And so what we saw really was that the prevalence of anxiety or depression began to decrease consistently across groups with time. So 2 in 5 persons aged 50 to 74 years reported mental health problems. And then when they began to get older, you saw 1 in 4 persons aged 75 years of age reported mental health problems. Next slide. Now, this is going to be looking at more of the social determinants of health again. And I think this is consistent with what we heard from the other presenters, and that they are significant drivers of mental and general health problems. And so what you see there, when you start, if you look at the social determinants of health, people are really concerned about food, and that was consistent with our previous presenters. And so when the basic needs are not met, food, income, you're going to see a significant increase in mental health problems. And the number one factor that impacted on the older adults' physical and mental health was food insecurity, persistent. Thank you. You could go to the next one. All right. So when you look at that and you think about the basic needs again, and there's the basic needs are consistent drivers of elevated mental health problems across all race and ethnic groups. And you could just see, and that it was consistent that people were really concerned about food security, not enough food, and income was another component. And we saw that the Latinx older adults appeared to be most impacted by food insecurity during the COVID-19, and those were the reported results that we have. So then we began to focus specifically on what we see in the Indigenous population, and we looked at the Indigenous this data from the Indigenous Wellness Research Institute, COVID-19 communities of color. And you can see the results there. And what we see is that 2 in 5, about 40% of the older adults participating in that survey met the criteria for elevated anxiety and depression symptoms. And I've been doing research on the Indigenous population as it relates to health equity, and I'm seeing that this is being quite consistent, but it's elevated even more so with COVID. And so, as with the other race and ethnic groups, the prevalence of anxiety, depression. So what we see is that it's consistent with all of those. So 1 in 2 individuals ages 50 to 59 years, which is about 50%, met the criteria for elevated mental health problems. And when you start looking at anxiety and depression together, that's 40%. And 1 in 4 individuals aged 70 years of age or older met the similar criteria. And when you start looking at the social determinants of health again, we see even, and this is in the Indigenous population, and that's again a significant driver of the mental and general health problems. And we see that they have more challenges, as with the other people of color, when the basic needs are not met. So what they did know, the Indigenous did know that they had really more concerns about inability to secure medications. There was low education and not having enough food as the primary drivers as it relates to mental health problems. Now, and within this population, social isolation and loneliness were also major drivers of elevated mental and general health problems. Now, so what are the health protective factors in the Indigenous population? So if you think about what you don't have, you can look at what you do have, and you can see that some of the, what are some of the drivers in terms of them that can keep them insulated from having mental health problems. And one is that if they have more social activity and not as isolated, then you see them doing better and more household income, having enough food. So what you see the reverse of not having is what you see as the health protective factors. Next slide. So what are some of the takeaways that we had from the studies and the research that we done in analysis of the data? What we found that was really concerning is the high rates of mental health symptoms among older adults of color, and it is especially high among the Hispanic and the Indigenous older adults. But we saw that in all the populations, and that was number 2 is that there was evidence of pandemic fatigue, and it started in the winter months with increased mental health symptoms, tracking with increased death rates. So when there was increased death rates, there would be increased mental health symptoms. And it got a little bit better over toward the end of the summer and the fall, and then it went back up again with the winter. And again, that's with the increase in the death rates. And now the data underscored the variability of the mental and physical health conditions across group regions of the country. So it's not a one size fits all. It depends on what part of the country that you're in. And so you need to, when you start thinking about policies, you want to look at what's going on in that area of the country, and you want to have policies that address what's going on in that particular area. And significant mental health symptoms were found most when the basic needs, money and food, are not being met. These are significant parts of the social determinants of health. And so we really need to pay attention to that. And it's consistent with the other research that we're seeing. And the other was that the oldest adults over 70 years of age had the lowest rates of significant mental health problems. The older they got, they seemed to do better as it related to mental health problems. So thank you so much.
Thank you, Dr. Kelly.
Mm-hmm.
And now we're going to move on to our last, this is something else. Our last member of the team, Dr. Karina Walters, representing the Indigenous Wellness Research Institute.
Yakoke, halito sahachifa tata pushi ganchan spa chabiti hoyo michi chatasi hoke, michi yakoke Oklakana. Good afternoon, everybody. My name is Karina Walters. I'm an enrolled citizen of the Choctaw Nation of Oklahoma, and I'm greeting you from the lands and territory of the Snohomish people. And I also said in my language, honoring all of our relations coming together in this way. So thank you for having us here. I'm going to go fairly quickly because I don't want to repeat too much what's already been said because our findings parallel the other speakers. I just want to acknowledge we have a number of community partnerships that help to make this happen. Next slide, please. And our survey is actually now one of the largest national studies to date. We have 8,549 completed surveys by adult American Indians and Alaska Natives. And this is really critical because raising the visibility of Native experiences is critical, especially since not only because we've been hit exceptionally hard, as I know a number of us already know, but we remain largely invisible and undercounted or misidentified in most public health studies, and particularly in the COVID-19 study. So we're very grateful to have this opportunity to collect this data and be able to share that information. Next slide. In terms of our sample, we're really happy. We have a representative sample. We actually, through our methods, we're able to have a proportional sample that represents all of the census regions that are aligned with the census data. And about 27% of our sample are from reservation communities, rural border town communities, and 72% from urban, suburban areas, which is consistent with our census data as well. Next slide. In terms of greatest sources of stress, and as you can see, similar to other communities, mental health was our top greatest stressor during this period, followed by physical health, financial stress, and then the piece that I'm going to highlight in a minute, social distancing, the stress of not being able to see family and friends, and the impact of those social distancing guidelines were not healthy for our community. So American Indians and Alaska Natives were facing the same plethora of stressors that are triggered and or exploited and made worse by this pandemic. Next slide, please. Similar to our ABPsi colleagues, we are also following a syndemic approach. And so the confluence of environmental and socioeconomic inequities and pre-existing health conditions create a perilous syndemic, especially triggered during these outbreaks. And I just want to highlight the main areas, actually exposure to COVID-19, basic needs are under threat, disruptions in connectedness, physical and mental health challenges, all of these work together to produce poor health. But I also want to highlight that there are cultural protective factors that help us do well, and I'm going to try to highlight some of those. I also want to acknowledge that there are invisible health effects from COVID-19, such as the impact of these public safety strategies. For our communities, there was a lot of prohibition of customary and cultural funerary processes that actually disrupted our mental and spiritual health and disrupted our communal abilities to fulfill our ancestral obligations. And that created enormous strain. So turning to basic needs and some of the issues, same as other populations, 60% of our people experienced pandemic-related job loss, huge levels of housing insecurity. One out of three people are feeling housing insecure, and nearly 40% are experiencing some sort of food insecurity. Next slide, please. And as you can see, although mental health was identified and physical health as major stressors, but when we asked people what they need the most help with, the greatest needs were, again, going back to food and meals, followed by health services and unemployment services, housing, and utilities. So some of those basic needs come to the forefront in terms of people saying, this is what I may be highly stressed with my mental health and physical health, but I need help with our basic needs. I also wanted to acknowledge that people also wanted cultural and spiritual help. 20% wanted help with traditional healing, 19% wanted further help with spiritual or faith-based care, and 13% needed actually economic support with their funeral services. Next, please. Physical health, next slide, is a major vulnerability and source of stress in the COVID-19 outbreak. And what we found is that about 21% of our sample is living with 3 or more health conditions. And this matters because these kinds of pre-existing intersecting conditions, such as hypertension and diabetes and lung disease, for example, can lead to more severe COVID-19 illness, increased vulnerability to longer hospital stays, and linked to poor COVID-19 related health outcomes and poor recovery challenges. In other words, things like long hauler symptoms. Also, pre-existing mental health concerns. At some point in folks' lifetime here, we saw that people already had high levels of pre-existing concerns, and those, of course, can become exacerbated during the pandemic, contributing to further physical health distress. So this physical stress vulnerability was very concerning. Next slide, please. Next slide, please. The other area that was important for us to gather data in was, how hard are we really getting hit by COVID-19 itself? So 25% were told by their healthcare provider that they had COVID, and another 24% reported that they actually tested positive for COVID. And of those who were older than 46 years old, they averaged a hospital stay of 6 days or longer. And interestingly, about 39% of the sample accessed traditional medicines or healing ceremonies to either manage their symptoms or to treat symptoms or illness after exposure. So people were utilizing traditional health as well. Important to note, Native adults between the ages of 18 to 29 years old were more likely to have COVID and be hospitalized than Native adults between 46 and 75 years of age. These are our childbearing years. This is a critical age group that is getting missed in most of the data that we do need to be paying attention to. Next slide, please. Because we have high rates of COVID means we're also experiencing high rates of COVID loss during the pandemic. And we know this is critical because research shows that being socially connected and having strong familial networks are strong predictors of resilience during natural disasters and serves as critical social, psychological, spiritual sources of support in times of these collective crises. But this pandemic has literally created ruptures in our support systems and our families. And we have experienced incredibly high levels of loss. So 54% had someone in their social circle get sick with COVID. 10%, 1 out of 10 people had someone in their circle die of COVID. And of those who knew someone with COVID, on average, they had 3.5 people in their social network pass away from COVID, and usually one person from their household. This is an incredible high amount of loss. And actually, we're seeing that our estimate of COVID deaths is 2.5 times higher than actual current published estimates. One thing I wanted to highlight here is that there was expressed a lot of COVID loss worries. About 25% of our participants worried about the impact of COVID-19 on cultural loss and loss of traditional knowledge and loss of elders throughout this pandemic. And 23% said that they were prohibited. The state or the tribe would not allow them to hold customary burial or memorial practices, which created high levels of stress. And then about 11% said that it was difficult to follow social distancing guidelines after the passing of loved one because of our cultural expectations and customary practices that include feasts, feeds, and sings and visits during ritualized memorial processes. And some people felt very conflicted and had a hard time keeping social distancing during that period. But on the other hand, our communities also came up with very clever ways to still maintain those practices. For example, I went to one where family members of the deceased provided to-go food plates during truck drive-by memorials. Next slide, please. And then I wanted to highlight the impact of disruptions in connectedness. Isolation and loneliness for collective communities is very disruptive. About 46% said that they were unable to care or visit a family member. So nearly half of them said that they had high levels of isolation from the social networks and extended family members that were disrupted their ability to provide care and increase their sense of loneliness. Next slide, please. I'll wrap it up. Mental health challenges then, of course, emerged. as a result of all of these stressors. And you can see over half had some kind of COVID-19 related PTSD, and 46 and 45% had depression and anxiety. Very disturbing sign is that about 46% started substance use for the first time or increased their use during the pandemic, and 24% seriously considered suicide. The highest risk groups were among the 18 to 29 years old, where 55% were deemed high risk, as well as 30 to 45-year-olds, 60% were high risk. 22% of our young people seriously considered suicide in the past month. Again, mental health distress highest in the childbearing age group. Next slide. Next slide. And then I want to close with some of the resilience. I mean, even though we've been hit hard by the pandemic, this data does reveal a story of hope, perseverance, and resilience. Our families and communities are generating creative ways to connect physically distanced, but still socially and ceremonially close. And so you can see over a third of our sample access some form of spiritual support during this to cope through the crisis. Praying for family, going to elders, talking to clergy, and so forth. Next slide. And compared to before, people are actually engaging in outdoor physical activities that actually help them cope through this crisis. Land-based healing has been critical to our communities, and our communities are accessing that during the epidemic. Next slide. And then finally, I wanted to say that a factor that's been really important is this did produce an opportunity for families to turtle up, literally come together and create opportunities to be together more as family, creating more togetherness. That included people engaging in, a third of our sample started practicing their traditional tribal languages again, working on American Indian, Alaska Native artwork and crafts and teachings, passing that on to the next generation. So that has been actually a really positive outcome from this process. I'm going to close with that to save our time and just say, Yakoki, thank you very much for allowing us this opportunity to share. Thank you.
Thank you very much, Dr. Walters. I'm going to, I included a slide that you had that a picture is worth 1,000 words. And this picture that was in your slide deck says it all about resilience. And, you know, we are still here, we're still standing. So with that, I know our time has run over, and I'm going to simply close by sharing. I won't be able to go into much of the details, but
Dr. Grills. Excuse me, Dr. Grills, we can do a time check, but according to me, it could be our East Coast, West Coast difference. You still have a good 25 minutes. It's only 1:36, and you're scheduled until 2 o'clock.
Okay. Yeah, I was thinking about making sure we have the full time for the discussion. So
Yes.
I'm going to eat into it for just like 3 minutes and hold on to your seats because I'm going to cover a whole lot so we can open it up for Q&A. So in addition to the information that you've heard so far, we did do additional deep dive study above and beyond the data that you've heard so far, particularly from the Latinx and ABPsi associations. And that was starting with the Community Coalition in South Los Angeles that did an additional study of 4,447 folks. These are the demographics: 55% Latinx and 32% African American. And since the pandemic, what people needed help the most with were the same kinds of things. So we're getting some triangulation around this endemic and the impact of multi-generational stress and trauma on our communities. And the greatest sources of stress, again, mental health concerns, followed by physical and financial, et cetera. But this is a clarion call to our profession, folks. What people are saying they need is our help. They need ways to address the stress of COVID that has impacted and compounded the stress that they've already been feeling from racism and structural and interpersonal. And the kinds of thoughts and activities that people were engaging in because of COVID, past historically traumatic events. So this is triggering people's recollections, both personal and family story and genetic. What's kind of baked into our DNA. They've been thinking more about spirituality and spiritual practices and praying to the Creator. and worried about historical traumas and stressors that were experienced by our elders. What have folks done to cope with stress? This one is really important, and I really want us to pay attention to. Not everybody wants or needs psychotherapy, and our community is telling us what soothes their soul. Talking, being in connection, in relation to one another. That whole notion of salvubona. Listening to music. Music is not just for fun. Music actually stimulates the vagus nerve, which then gives it more variability, which helps us to better manage stress, which protects our minds and our bodies. Exercise, hobbies, TV watching, etc. In addition to what the Community Coalition did, the United Coalition East Prevention Project did a follow-up study, or an additional study, focusing in on the unhoused residents of the community. 83% of the sample came from the notorious Skid Row, which is one of the largest homeless areas in the country. And it's almost nearly half of the unhoused residents, oh my God, come on, are African American. And the kinds of issues, what's number one for folks? Mental health again. Again, our folks are saying we need help with managing our minds, keeping our minds sane, etc. And then access to food, concerns about impact on the community, etc. are important. Stressors, and what are people doing? The relational pops up again. So how do we create more spaces and places for our people to be in community with one another? That in and of itself is healing, right? We are each other's medicine. And then listening to music, engaging in exercise, etc. But in terms of the emotional distress for people experiencing homeless in Los Angeles, which was the 711 sample size, folks are saying that their levels of nervousness and stress are high to very high, 55% of folks. And then this was the research team from the unhoused people study. Lastly, headlines from the subject matter experts. And this one I'm going to try to go through really quickly. First of all, Derek Hamilton was our economics expert, and he looked at racial disparity and found that it persists or worsens with higher levels of education. So getting that degree does not protect you, and that includes college degree attainment. In comparison to white men, Black women, Latinx women, and Latinx men are crowded into essential work, which is referred to as occupational crowding in economics. The crowding index is highest for Black women, who are 80% more likely than white men to be in a low-wage, high-health risk occupation, followed by Latinx women. Fourth, while income is often used by researchers, policymakers, et cetera, to describe local economic conditions and drive policy decisions, it is an inadequate indicator of economic well-being. We need to press for folks to stop using that as the primary indicator of economic well-being, mobility, security, and especially across race and generation. Wealth is the better economic indicator. Next is Cornell Belcher, who did our polling. At the time that the poll was done, the issue was not vaccine hesitancy, it was vaccine access for the community surveyed. And moms, particularly 41% Latina and 38% Black, Africana, and women 18 to 49 were the least confident about COVID vaccine safety. So compared to the general population across Black, Latinx, and Asian American Pacific Islander populations, vaccine skeptics are much more likely to have consumed negative information or no information about the vaccine. Perceptions of the vaccine safety are a much better predictor of people's intent to vaccinate than perceptions of its effectiveness. And across racial groups, we shared a concern about the quality of healthcare available to communities of color, and that lack of trust in healthcare that we receive, the substandard care that we receive, is an important factor to consider in people's hesitancy. Dr. Stella Yee looked at issues in epidemiology. As of April 21st, 2021, racial ethnic group categories were missing for 39% of COVID cases and 17% of deaths in national data being used to drive policy and decision making. First, they force the racial category on us. Then when it's convenient, they don't use it so that it doesn't expose disparities. Another thing that she looked at was restaurants. So across New York City neighborhoods, Asian restaurants, food retail stores, and produce vendors had higher closures and slower reopening rates than non-Asian restaurants. And then due to food outlet closures, there would be a 20% reduction in fruit and vegetable consumption due to the pandemic in the sampled New York neighborhoods. Why is that important to know? That has a direct impact on, nutrition has a direct impact on health. The poorer your health is, the more at risk you are for COVID. Nines Ponce looked at epidemiological work as well, and what she found was that approximately 1 in 4 students who, no, that's not Nines. In many public-facing data systems, the Native Hawaiian Pacific Islander category is not reported or is aggregated in an other race category or are aggregated with the Asian group. That is extremely problematic and dangerous because it covers up the important differences that are happening within those the ethnic groups in that population. Currently, only 21 states report on COVID stats. Next, Megan Kuffeld in education did a study, and she found that approximately 1 in 4 students who tested in terms of academic testing last year were missing. Again, 1 in 4 students disappeared in the fall 2020 data. There's a higher percentage of missing test takers that were Black or Latinx and attended schools serving a higher proportion of students living in poverty. And then math and reading test scores from 2.1 million BIPOC students in grades 3 to 8 found math achievement was significantly impacted in the fall of 2020. And male students of color and students of color attending high poverty schools were the least likely to achieve typical learning gains during the pandemic. So the pandemic has hurt our children in terms of academics. And then lastly, Drs. De La Cruz and Duque did a study on social policy health economics. And mothers, we are paying a high price, carrying a heavy load. Unpaid work falls largely on mothers during the pandemic, and their workload increased. We also found that during the pandemic, mothers are spending an additional 51 weekly hours on childcare and housework compared to 20 hours for fathers. And this will widen the existing gender gaps in employment, income, and mental health. Mothers reported also higher levels of depressive symptoms and anxiety symptoms compared to fathers. So I'm going to stop my screen share, but I do want to say that this would not have been possible, first and foremost, with the leadership of Representative Karen Bass, who put out the first call for help and then joined forces with the other congressional caucuses. And she, along with the Urban League staff and myself, really did a full court press, if you will, to raise the funds to do this. And so this project was funded by these foundations that you see here, with some additional funding added and support from the National Urban League. So I'm going to stop sharing and ask my colleagues to cut their cameras on and join me, and invite our community to share their questions and discussion with us, which they've already started in the chat. I've been enjoying the conversations in the chat. And Madam President, I'm not sure from the Mbongi, I believe that people can just chime in with their questions, or they're going to come primarily in the chat.
I believe in our Remo platform, they're going to come primarily in the chat. And there are some questions in the Q&A area. I don't know if you saw those, Cheryl, because in this platform, you can endorse certain questions to move them up.
I see. Okay. Okay, so let's see. I'll start with the question, how were the states chosen, and is there a reason Illinois and New York weren't included? And I guess that would be to all of the panelists who may have had surveys that did or did not include Illinois and New York.
I'll start. And for the ABPsi survey, we were purposefully trying not to go into areas that might go beyond the resources. I think that it's also worth saying that we all had limited resources to do this as well. And we also were purposive in selecting areas where we had some members who could assist as well with the on-the-ground data collection.
Anyone else want to say anything about regions or areas that were selected for their study?
When we met with the Congressional Hispanic Caucus, they were particularly interested in collecting data from non-traditional places or cities that have large Latinx populations. They wanted us to go to more rural places or places that are understudied.
And then there have been several questions related to how people can access the slides. So the National Urban League will be the first to post both the reports, an executive summary that is about 22 pages long. I know, because there's so much data, we couldn't end up with a traditional 2, 3, 5-page executive summary. That executive summary will be posted on their website, and some of the slides that you've seen today will be embedded within that executive summary. In addition to that, each association's independent study will also be posted on the Urban League website, along with a link to each organization's website, each association's website, where they will be able to post their own study findings as well. So you'll see the slides embedded within a narrative report, and you'll see much more than what was actually covered today. But so that should be in about 2 weeks. It's right now going through copy edit and graphics design for posting. ABPsi will be able to send out, and each association will be able to send out a news blast that the slides are available, that the reports are available to people. Is there a link between elders' hesitancy and youth understanding of COVID? I don't know if anyone wants to take that on. Is there a link between elders' hesitancy and youth understanding of COVID? And Michelle, if you want to elaborate any more on that question, that might be helpful as well.
I can take a crack.
Okay.
At least at Native Hawaiian and Pacific Islanders, we actually had the least hesitancy in the elder population. And what that reflected was a recognition of their vulnerability, because they weren't, they were isolated the most, but they were also, that generation is being lost at such a high rate in Pacific Islanders. And so we had, the least amount of hesitancy in the elder group that was surveyed. And actually the largest hesitancy came within the middle, the 25 to 44 year age group, which kind of surprised us, because that group predominantly was about 44% essential workers. And we didn't understand that this, what was making them so hesitant in regards to getting the vaccine when they're the ones at the highest risk of exposure. And so, and then our younger group sort of was in the middle between those two. But it also helps us going forward in restructuring our messaging, you know, that the vaccine isn't just for you. It's to protect that group that knows that they're vulnerable. That elderly group that says that, you know, this is something that they're afraid of. This is, you know, our cultural value in protecting our elders and adhering to what they think is important. That follows, you know, our cultural way of passing on information. And so, you know, the survey kind of reminded us of things that we knew were important to us, but now we have the data to sort of help support that and sort of structure our resources to be aimed in that direction.
Hi, Karina.
Yeah, I was just going to piggyback on what Dr. Samoa is talking about, because in the American Indian Alaska Native communities, we saw something very similar, especially the focus on wanting to make sure that the elders and traditional knowledge keepers were vaccinated. So the focus was on getting a vaccine to protect others, especially our culture bearers, because we recognize how devastating that would be to lose an elder. So there was a lot of support for elders getting vaccines, and vaccine media campaigns that actually focused on helping to protect the elders and protecting our knowledge and our knowledge keepers. At the same time, one thing I just wanted to highlight, we just ran some analyses given the Delta variant and looking at states. And so what we found was that the folks who have the highest levels of hesitancy are in, not coincidentally, the same states that are experiencing the greatest outbreaks right now. So, you know, so we have some work to do here. So our folks in Oklahoma and Texas and Mississippi and other regions, Florida, we're pretty worried about, because they are the ones who also express the highest levels of vaccine hesitancy in line with what we're seeing with outbreaks right now. So.
Thank you. And then there's another question. Many of our community members are harder to engage in social science, public health survey research. What steps were taken to ensure truly representative samples rather than samples of convenience? So I'll start with, you know, I know, for example, with the Community Coalition, we collected that 4,447 surveys. And then at the same time, with the unhoused people who are experiencing homelessness, another 711, we collected that data in 3 months. And the only way that we were able to do that was partnering with local community-based organizations who have access to members of our community, and they are trusted members of the community. So I would say that we really need to look at research going forward as something that always happens in partnership with the community, not just to access the community, but to also inform what we do and how we do it. Karina, you had an incredible experience of having one of the largest data sets collected on Native Americans in the history of this country. You want to share how that happened?
I just want to highlight that, I mean, doing online surveys are very challenging. So first and foremost, we spent an inordinate amount of time cleaning it to make sure that we got rid of anybody who was entering in that shouldn't be in our sample, bots, as well as folks who aren't really Native, trying to get access to prizes and things like that. So I have to say that almost took almost as much energy as trying to create a sample that was representative. So I just wanted to point that out, and I know we're not the only ones. Everybody put a lot of work into ensuring that the data is valid, culturally valid, and representative. In terms of our sample, I think, again, similar to others, our community partners made a huge impact. We were able to work directly with community partners that had lists of their members of about 20,000 people. For example, the Center for Native American Youth put out a call to 20,000 of their people in their communities. And then we had a group of youth, Native youth, who made a call as well to get the call out to people. So we had a great ripple effect. We were planning on limiting and trying to get an approximate representative sample and do specific targeting for urban and rural and reservation, as well as regions of the country, which we focused on. But actually, because our outreach was so strong and our community partnerships were so strong, it naturally filled the way it should. So we were actually really very fortunate. But again, I think that's a testament to the importance of doing this kind of work in partnership with our communities and community leaders who really know the community, are of the community and by the community. It makes all the difference in the world. And the last thing, a caveat on that, we didn't go through services. We didn't, this is a little bit different. We didn't hit a lot of surveys, health surveys go through agencies that are service connected. We had some of them, but mostly we went through community-based organizations and culturally based organizations. And I think that helped us go into parts of the community that may or may not be connected to health services, which I think was really important.
So Dr. Grills, this is Theopia. Before, because we need to close. However, I have placed 2 questions that came in from our YouTube page because this is being live streamed. So if you could see that and choose which one would be your last question. Name, it'll clearly say question from live stream. And then we'll turn it over to Dr. Tomes to move us through the rest of our convention day. While Dr. Grills is looking at this very specifically and briefly, I want to say thank you to each and every one of you for accepting the invitation to be here and to share this information. Clearly, we have many more conversations to be had, and this is a great starting place.
Okay, so I guess I'll go with the question about our children, and it's, where is it? I lost it. There have been significant numbers of our, no. Where did it go? Theopia, can you just tell me what the question was about because
the second question can go to Dr. Randolph to bring into her presentation this afternoon. The question is, it's from Brandon Gamble, one of our members. The data about students, what are the recommendations from the panel to address, for example, the challenges with math, boys continued and worsening academic outcomes? So I'm not sure if that was a specific focus in here, but what, if anything, was learned about the academic experiences of our youth?
So actually, NWEA, which is the organization that did the research on education under Dr. Kuffeld, they actually had a series of policy recommendations that went to the different congressional caucuses. Among those policy recommendations were things like increased technical support, increased access to after-school tutoring, greater attention to the curriculum and how things were being taught in the classroom, because it's not like the scores were great before COVID. It's just that COVID exacerbated it and made them worse. And there also needs to be special attention to what's happening in the environment in schools that in fact may be working against the ability of boys to be focused. I mean, there's a lot of caustic anti-Blackness kinds of things that happen in the schools and in the classrooms that become major sources of stress and distraction from children being able to address their or express their educational abilities. So, but when you go to the link, you'll be able to see in the report from Dr. Kuffeld and her team all of the policy recommendations based on their experience of collecting this data nationally. And I believe that data was about 2 million students.
Madam President, because the question is from YouTube and might be from the public and so won't be in our event, I just want to say briefly the coping mechanisms were largely around talking to family and friends.
And then, Madam President, if I might just take license and say for 30 seconds, there was a good question about what are the next steps for this work. And our next steps are to try to move forward with both follow up with each of our congressional caucuses to make sure that this data translates to public policy and legislation. to then share the data with the national civil rights organizations to make sure that their campaigns are informed by these findings, and then to return back to the funders. There were about 80 plus funders that came to a briefing, I believe, and we will be going back to them to say, we need you to fund phase 2, which will be a deeper dive into certain areas that were revealed in the findings from phase 1. And that focus would be a collaborative decision between the alliance organizations, the elected officials, the civil rights organizations, and all of the community-based organizations that were part of this process. We're truly trying to make this a participatory research endeavor.
Wonderful. Thank you so much for this. And thank you to our listeners who are visiting us on the YouTube. This officially ends this part of the presentation. We're going to turn it over to Dr. Thomas, who will speak to those of us who are in the convention space. Please remember, anyone of African ancestry can join the Association of Black Psychologists, be part of our convention. You do not have to be a psychologist, but be part of the family. Dr. Thomas, and thank you to the panelists.
Thank you, panelists, for this important information. Okay, we're going to break out into our breakout sessions that we have. And again, we have 3 breakout sessions. Just before I announce those breakout sessions and the locations, I want to remind people that in the chat, you will see the CE and CABP evaluation form. It has been posted by Dr. Sabrina Scott Lorestill. So look for her name and you will see the click or the link for that particular evaluation for CEs and CABP. So we will have 3 concurrent breakout sessions that will take place. The first one will be From Black Girl Magic to Black Burnout, the continued quest for wellness. It will be right here in Umoja Building 1, so you do not have to leave. Please note that is not for CEs. I did announce earlier it was, but I stand corrected. That will not be for CEs, but it will still remain in Building 1. The second presentation is an examination of Africultural coping and racial identity on suicidal ideation among college-age Black women, which will be for CEs. That will be in Building number 2, NIA. The third one is Gender Differences and Cultural Mistrust and Mental Health in the Black Community, which will be in Building number 3, Kuumba. That will not be CEs. Again, you can find the banners for each building on the right in Remo. They're highlighted in yellow. Again, Building 2, NIA, and Building 3, Kuumba. Also remember, the convention booklet is posted for you. It will be on the left in Remo where the floors are. You will see the 2021 icon. You just click on the icon and then we'll open up the convention booklet for you. Again, have a great convention. Also, one final announcement before we depart for the breakouts. There has been a change for our 4 p.m. breakout. There will be still the Being and Becoming Living My Art in our personal lives, relationships as leaders. However, it will take place in Zoom. We're updating Remo so that we can put the link in here for you. You'll just click on that link and then it will take you to the Zoom session. I will announce this again at the end of the 3:45 p.m. sessions, Eastern Standard Time. Thank you, and we're going to go to our respective rooms.